This patient had uneventful cataract surgery in 2006 with placement of a zonal refractive multifocal intraocular lens. The only issues encountered at that time were a mildly myotic pupil, and with the mild myopia, a capsulotomy ring was placed electively to ensure excellent centration. In 2007, a YEG capsulotomy was performed for mild PCO, and he presented in early 2011 with monocular diplopia, a decentered lens, and vitreous prolapsed into the anterior chamber. Epi-sugarcane was used to dilate the pupil intraoperatively, and the anterior chamber was then irrigated with non-preserved triamcinolone to stain the vitreous. A pars plana sclerotomy was then fashioned, 3.5 millimeters posterior to the limbus. And an anterior vitrectomy was undertaken via this incision using an anterior chamber maintainer and the anterior vitrector to sever the vitreous bands. The tip of the vitrector was then used to elevate the optic through the intact anterior capsulotomy, which was well positioned with regard to the pupil. Once the lens appeared stable, the anterior chamber was emptied of its stained vitreous remnants. And the position of the lens vis-a-vis the capsule was inspected, and it was noted to lack full capture of the optic. Going through the pars plana, once again using the viscoat cannula at this time, the optic was confirmed to nasally be in capture, and temporally the optic was elevated into a proper position, achieving a cataract configuration of the anterior capsulotomy, and this was confirmed in the anterior chamber using a Kugel hook. Myocol was then placed to ensure that all vitreous bands had been severed and the anterior chamber was emptied of its OVD. The patient achieved an excellent result with a stable lens.